Another example, AVMs. We were all taught not to use coils, and I wouldn't. In this particular instance, however, she was a 26-year-old girl with a bleeding, huge varix in her axilla. Sometimes you have to do what you have to do. So a detachable coil was I put detachable coils in to stop the acute bleeding from the huge axillary varix, and then went on to treat her shoulder AVM. And this is onyx. And eventually she came back twice more for more onyx and glue, and eventually all of those went away, but this is old enough that I couldn't find the most recent examples, but I see her each year in clinic, and she hasn't required treatment in the last 2 years, so I'm hopeful that with the onyx and the glue, we're able to hold that back down, and she has not yet formed another huge varix. This is even older, I believe. Yeah, this is a person who was presented initially at extreme IR, person who was bleeding profusely. Let's see, how do I show the pointer? There we go. My partner coiled, just like you've seen, a massive, this includes a Benson guide wire, an enormous number of coils to treat this SMA problem. But then he came back a few days later and was bleeding profusely from this vesuvial hole in the celiac artery. And it's a difficult place to coil, and so instead we stent grafted it. So it's another example you've been shown. This is back in 2001, and that's a wall graft, but with long-standing patency of the celiac artery, which is something I was not even sure that we were going to obtain, but we were just trying to save the guy's life. More recently, this is a person who came in. He came in with these coils, and over the next, he continued to bleed despite my embolization of the gastroduodenal artery. When we couldn't find bleeding, he was bleeding profusely into his bile duct, and then my partner's embolization of left hepatic arterial branches, and I had gone in and done the superior pancreaticoduodenal, empirically trying to stop the bleeding, but he continued to bleed, and our surgeon, who didn't want to take this very sick man to the operating room, said, "Can you please just stent graft the hepatic artery?" And so it made sense. So when I went in to stent graft the hepatic artery, I changed the configuration of the artery and filled his bile duct with blood, thus demonstrating that's where the problem was. And so, again, an example of stent grafts in the treatment of people who have active bleeding. He left the hospital stable 9 days after the procedure after having been transplanted emergently hypotensive. And then this one is really off task, but it shows the importance of thinking outside of the box. This is a 26-year-old woman who I was not initially involved in her care. I was called to her room by my junior partner when, after having obtained this venogram showing her her vena cava stenosis following her second transplant, he put in a 16-millimeter balloon and dilated her cava. And so the next picture is what I saw, which was her bleeding to death in our suite. And I came in and he said, "Here's what I saw in the venogram." I said, "Oh my God." And I talked to the lady, and she was still conscious at that point. And I said, "Put your balloon back up." And so he put the balloon back up. She remained conscious and actually asymptomatic. And then I called the chief of transplant, who was at a Starbucks. And then he called his partner, and then she went immediately to the OR with the balloon in place, and they fixed her cava. And so the thought there is sometimes you can't fix it. And I think you guys have seen that. You've made points that some people belong in the OR. This is one of them. And she came back later because she had ascites and problems with her hepatic veins. And so eventually I stented her hepatic vein, and this was now years ago. Here is January, and she's doing fine with a stent in her hepatic vein, and she's okay. But that was an example of think outside the embolic box. And then finally, this is a lady who was I should go back for that history. She's a lady with a huge pelvic AVM. She had been seen in an outside hospital. She was bleeding. Turns out she had been embolized by one of my partners a couple years earlier, and when she came in, I saw that embolization had constituted a whole bunch of coils inappropriately placed throughout her arteries. And so here was her AVM, and that's a gonadal vein, which is the size of her vena cava. And so I, over the course of a few days, went in and used I'll just show we'll go quickly through it. Basically, there's a whole lot of onyx there. And then she came back and got glue. And eventually, we got her down to that, still filling from tiny little blood vessels, but stable. And I was pretty happy and was going to bring her back again to try to cut those off, but she developed dilated bowel loops, and they were concerned about bowel obstruction. So she went to the OR, and what my friend, the surgeon, found when she was in the OR was that she had adhesions in her bowel, but it wasn't ischemic. And he wanted to know whether it'd be okay for him to ligate the ovarian vein. Yeah. So I didn't know what to say, but I said that seems like a reasonable thing to do. He did. She came back to IR the next day for a follow-up, and this is her picture, which is pretty impressive. And this is only 4 months ago. I haven't got long-term follow-up, but I have clinical follow-up, and she's fine. So we will, over the course of time, I'm sure the AVM is going to come back. But the idea is, again, look at all the things available to you, and if you need to work with your surgeons, then do so. And then finally, we've already talked, I won't go on much longer, but just for completeness, you have to close the hole once you're out. And if the patient is coagulopathic, that can take longer. There are closure devices. I use predominantly a star close. It doesn't always work, but it often does. And sometimes if it doesn't, pressure is a good thing. And this is an example of a person who had every problem with it. I put a catheter in her. She had end-stage renal disease, acute renal failure, low platelets, and we failed to correct anything, because this is, again, happily an old case. And when I put the catheter in, it started bleeding out her neck. But with pressure, she did just fine. And then finally, if people have not yet seen this is made by Datascope. It's an inflatable pressure dressing, which we have used with a fair amount of success, predominantly in venous things, but can also be used following oozing in your coagula patients as well. So there it is, broken down into 3 parts: preparation, procedure, and closure. Thanks for your attention.